58-year-old African-American woman. This patient has New York Heart Association Class 3 symptoms, which is moderately symptomatic. She was recently hospitalized due to heart failure. And during this visit, when you see her back, you need to evaluate for ongoing and new symptoms, optimize the evidence-based therapy to improve symptoms, to reduce her hospitalization in the future, and to increase her survival. So, what about heart failure? Currently, there are about 5.8 million people in the U.S. that suffer from heart failure, 23 million worldwide. That's from a very recent publication, 2015. As of 2012, 2.4% of the U.S. population was reported to have heart failure, and the number with heart failure is estimated to surpass 10 million by 2037. It's the leading cause of inpatient hospitalization in our country. Total cost is projected to grow from $44+ billion in 2015 to $97 billion by 2030. About 20% die within the first year of diagnosis, while 50% of patients with heart failure die within 5 years. It has a natural history much worse than almost all forms of cancer. 35% with class 4 heart failure, symptoms at rest, die within 1 year. When you look at the prevalence of heart failure, at all ages, men are at slightly increased risk, and this gap has widened, even though women often live longer than men. When you look at ethnicity, blacks are at greater risk for heart failure, mostly because they have burden of hypertension with preserved EF heart failure, than whites, than other groups, and then Hispanics. But all ethnic groups continue to increase in their prevalence of heart failure. So our patients has symptoms of heart failure in a recent echocardiogram that showed a reduced EF of 30%. So the first thing we have to ask is, does the patient have HFpEF, heart failure with preserved EF, or HFrEF and reduced EF? And HFrEF is much different and distinct from HFpEF because the evidence base for heart failure with reduced EF is enormous, that we'll talk about. But the evidence base for HFpEF is almost non-existent. We have no clinical trial that has shown us a particular drug in preserved EF heart failure will allow a patient to live longer than another, or placebo. We have so many trials in HFrEF that prolong life, including ACE inhibitors, including ARBs if they're ACE intolerant, including beta blockers, specific beta blockers, while the class of ACEs and ARBs look very, very favorable in heart failure with reduced EF. We have isosorbide hydralazine, which prolong life. We have mineralocorticoid in HFrEF that prolong life, but not in HFpEF. Heart failure is a complex clinical syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the ventricle to fill HFpEF or eject HFrEF blood. It's either a pumping problem with a reduced EF or a pressure-volume relationship abnormality from HFpEF in which the ventricle, for the same amount of volume, develops an inordinate pressure, HFpEF. The cardinal manifestations of heart failure are similar regardless of etiology and regardless of HFrEF or HFpEF, in that they present similarly with shortness of breath and fatigue, which often limits their exercise tolerance. Our patient couldn't do daily chores in the house, and fluid retention, which may lead to pulmonary congestion from left-sided heart failure to right-sided heart failure, translated into peripheral edema. The pathology may affect heart size, wall thickness, and ejection fraction. So, HFpEF, LVH, hypertrophied heart, long-standing hypertension in the middle. HFrEF, dilated cardiomyopathy, non-ischemic cardiomyopathy, thin ventricular wall, large interventricular cavity. HFpEF, ejection fraction 70–80%, yet they present in the ER with shortness of breath and volume overload. HFrEF, same presentation in the ER, but ejection fraction 20, 30, 35%. Can't differentiate these patients, except S3 more likely in HFrEF, S4 in HFpEF. Okay? Large heart with displaced PMI, more likely in HFrEF, as opposed to a thickened heart, not displaced PMI, in HFpEF. Otherwise, you really need the ejection fraction and the echo. So when you look at all the causes of heart failure, Smoking, diabetes, dyslipidemia, obesity. If they have the above with systolic dysfunction and HFrEF, they often have underlying atherosclerotic cardiovascular disease. All of the causes can be similar, and HFpEF on the bottom we'll talk about a little later. In terms of the stages of heart failure, we'll review this in a minute, but normally stage A and stage B are asymptomatic, stage C and then stage D are symptomatic. This is a very nice slide that shows us the differences. On the far left is the 78-year-old white female with 45 years of hypertension that's been poorly controlled by your history, who comes to you with shortness of breath after a recent ER visit for volume overload. She's got huge LVH, a small cavity. She develops an inordinate pressure for a given amount of volume on a Saturday night when she's having potato chips and beer, and she's got HFpEF with a grade EF. You're normal in the middle, and on the far right is the dilated cardiomyopathy, large interventricular left volume cavity, but still an ejection fraction of 25%. Two systems are very important in heart failure, regardless if it's HFpEF or HFrEF, and that is the RAS system. No particular axe to grind here. ACEs are excellent drugs in patients with heart failure with reduced EF, but they are associated with cough and angioedema. ARBs in the patient that is intolerant of the cough. Remember, heart failure itself can cause cough. But all RAS blockers reduce vasoconstriction, sodium and water retention. They have an interplay with the sympathetic nervous system and cellular proliferation. The other system that's very important, especially in blacks more than whites, is the nitric oxide system. And basically, all of us, whenever we have to vasodilate, be it through exercise, sexual intercourse, whenever we need more demand, we vasodilate our vasculature. And we do so by increasing endothelial production of nitric oxide. Nobel Prize was won for that discovery. We produce nitric oxide from L-arginine. We now are able to vasodilate, as opposed to superoxide, which is an antioxidant, which can form a yin-yang relationship. So we'd like to have more nitric oxide, a reduction in superoxide. Superoxide then goes to form peroxynitrate, which is an oxidant and causes cellular damage. And this system in heart failure is important, and it's upregulated in African Americans, where there's a reduction in nitric oxide synthase and an increase in superoxide formation. This led to the formation of the AHEF trial, which I'll review for you. That is the combination of isosorbide dinitrate, TID, that allowed the stimulation of nitric oxide, and the blockade of superoxide and peroxynitrate from hydralazine, which not only blocked nitrate tolerance, but also causes less oxidation. So we have a balance of RAS, sympathetic nervous system overdrive on the left, and endothelial nitric oxide production on the right. We have evidence in heart failure with reduced EF for the use of a RAS blocker, ACE or ARB, beta blocker, metoprolol long-acting or carvedilol preferred, and mineralocorticoid receptor antagonist, spironolactone or eplerenone. Eplerenone, a little more evidence-based post-MI, spironolactone in heart failure class 2, 3, or 4. On the right, we have, especially in African Americans, the use of isosorbide dinitrate hydralazine. We thought we had a drug that was a NEP inhibitor with an ACE inhibitor called omapatrolat, but was associated in 2007 with severe angioedema. But now we have a drug just approved that I'll review for you called Entresto from Novartis, which is a combination of an ARB, their ARB valsartan, with sacubitril, which is a NEP inhibitor, and it'll make more sense in a minute. So the staging of heart failure is stage A, B, C, and D. We see in primary care stage A. These are high-risk people. They have underlying disease in hypertension, diabetes, alcohol abuse, or a family history of cardiomyopathy. They're at high risk of developing heart failure but have no symptoms, and they have no structural changes of their heart. Stage B have structural changes, often LVH or their post-MI, but they are also asymptomatic. So stage A and stage B are asymptomatic individuals. seen in a primary care practice that we try to do the best to reduce their chances of ever going on to develop heart failure. Stage C are the patients we also see who are symptomatic with either HFrEF or HFpEF, and they have prior occurrence symptoms of heart failure. And stage D are the patients that we often refer to cardiologists who are in and out of the emergency room who may need device therapy or augmentation devices to decrease their in and out of the hospital. Let me just review the most recent American College of Cardiology Foundation and American Heart Association guideline, and it came out late in 2013. This is the most recent update in heart failure, and these are class 1 recommendations that should be performed in all patients who have symptomatic stage C disease. A history and physical, a family history in patients with a dilated cardiomyopathy to know if they have the family history of a dilated cardiomyopathy. You want them to have their weight, you want to know their volume status, a CBC, a UA, electrolytes, lipids, a liver panel, and a TSH. Nothing striking. An EKG and a chest x-ray. Nothing striking. However, they will pay, and they do recommend, as a class 1 recommendation, a 2D echo with assessment of LV systolic function. What's the ejection fraction? That's really what we need. In addition, at baseline, and I'll talk about this in a minute, we need a BNP or an N-terminal BNP. Now, the normal BNP is less than 100. The normal N-terminal BNP is less than 300. This assesses the likelihood of heart failure when it's elevated in those ambulatory with shortness of breath, or when there's acute decompensation, when the etiology for the decompensation is uncertain. But we don't serially do BNPs. We don't chase BNPs. We have to be sparing in our use of BNPs, even though they have prognostic and diagnostic capability. Repeat measurement of LV function with an echo should only be done when a significant change in clinical status has occurred and you're confused. So the COPDer who now presents with volume excess, a BNP can be very helpful. If it's just from COPD, it shouldn't be elevated. If it's from COPD with heart failure, it will be or might be elevated. So these can be helpful, as can a repeat echo, but used sparingly. A class 1A recommendation, natriuretic peptides, 2013 update. In ambulatory patients with dyspnea, measurement of BNP or N-terminal proBNP is useful to support clinical decision-making regarding the diagnosis of heart failure, especially in the setting of clinical uncertainty. Class 1A, measurement of BNP or N-terminal proBNP, is useful to support clinical judgment for the diagnosis of acutely decompensated heart failure, especially in a setting of uncertainty for the diagnosis. So new onset volume excess, multiple risk factors, you're unsure of the etiology, BNP, or proBNP, whatever you're more comfortable with. The patient then gets admitted. You don't need to repeat the BNP. However, on discharge, as the primary care doc who's going to see them back, if they're tuned, you'd like to have a BNP to know if they decompensate, what was it when they were tuned up? But I would not chase BNPs in the hospital. I would not get serial BNPs. Use it sparingly. It can be helpful. So this is the staging system, 2013, stage A, B, C, D. We already reviewed it. Stage A and B are asymptomatic. They are at risk. They are really our bailiwick. They are the patients that we would like to be able to prevent heart failure in. Stage C and stage D may be ours, certainly may be the cardiologist, especially in refractory heart failure, stage D. And one is prevention, one is treatment. So in terms of prevention, we've got healthy heart lifestyle. We want to prevent vascular coronary disease. So what do we have? Well, we may have ACEs or ARBs in the diabetic. We may have statins. But in stage B, when they have LVH from hypertension, we may have ACEs or ARBs. Certainly, we're going to control the blood pressure, beta blockers as appropriate, perhaps statins. In stage C, look at all the, when the heart failure is preserved, what are the goals? Symptoms, improve quality of life, prevent hospitalization, prevent death. But in terms of the therapies, other than a diuretic to relieve congestion for symptomatic control, we have no recommendations. Now, when the ejection fraction is reduced, we've got our ACE or ARB, we've got our beta blocker, we have our spironolactone or eplerenone, we have our hydralazine or isosorbide in select patients, we have DIG in select patients. When Dr. Piziak and I went to medical school, we had no ACEs and ARBs, we had none of these other therapies. We never used beta blockers in heart failure like we do today. They caused heart failure. So what did we have? We had diuretics and DIG. Now DIGE is at the bottom of the totem pole, not at the top. And we won't talk about stage D very much. The guideline talks about the recognition and treatment of elevated blood pressure. Hypertension. Hypertension may be the single most important modifiable risk factor for heart failure in the U.S. Hypertensive men and women have substantially greater risk for developing heart failure than normotensive men and women. We need to control blood pressure. So the patient has persistent symptoms despite optimal neurohumoral blockade with valsartan BID and carvedilol BID. Fixed-dose combination, isosorbide dinitrate and hydralazine in this African-American woman should be added to the treatment regimen. She's still symptomatic. She can't do her daily chores. Fixed-dose isosorbide hydralazine is the only evidence-based guideline treatment that is recommended at this time for this patient, in this patient with class 3 HFrEF. What does the guideline say? The combination of hydralazine and isosorbide is recommended for African Americans with New York Heart Association class 3-4 HFrEF on guideline-directed management therapy. Our patient is on that. Valsartan, carvedilol, still symptomatic. What are we going to do? A combination of hydralazine and isosorbide can be useful for HFrEF who cannot be given an ACE or an ARB. So if you can't use that for whatever reason, you could use this with a beta blocker, but it's a 1B. This is a seminal study in 2004 looking at placebo-controlled double-blind randomized trial in self-identified blacks, African Americans with heart failure and HFrEF, reduced EF. The addition of a fixed dose of isosorbide dinitrate plus hydralazine as standard therapy for heart failure, including neurohumoral blockers, is efficacious and increases survival among black patients with advanced heart failure. Over 1,000 individuals. The objective was to demonstrate the safety and efficacy of this combination compared with placebo in self-identified African American patients with moderate to severe heart failure concurrently receiving standard treatment. Patients were self-identified. They had class 3 or 4 heart failure for more than 3 months. There's their EF. They were on standard therapy. In fact, their background of therapy was phenomenal. And then they double-blindly were randomized to either an up-titratable dose scheme of isosorbide, dinitrate, and hydralazine, or placebo. And what did we find? Mortality was significantly reduced at 6 months. Quality of life was significantly improved on the far right. And first heart failure hospitalization was prevented significantly by adding isosorbide hydralazine on a background of therapy of an ACE, an R or an ARB, a beta blocker, with or without a mineralocorticoid receptor blocker on a diuretic. Phenomenal study. They initiated and titrated in the AHF trial a fixed dose combination tablet, TID. They began with 20, 37.5, and they ended up on, at the bottom, 120, 40 TID of the isosorbide, and 75 given TID of 225. You can give it either as a combination pill or 2 generic medications. Let's move on. This is the most recent addition, just recently FDA approved less than 2 weeks ago, in a drug that combines the ARB valsartan with a neprilysin inhibitor. We'll talk about that. Head-to-head, double-blind, randomized in HFrEF against enalapril, 10 milligrams BID. The way enalapril was given in the SAVE study, SOLVE study. How does this drug, which was called LCZ696 and is now called Entresto, trade name product, what does it do? Well, this LCZ696 combines sacubitril, which is a neprilysin inhibitor, which basically allows an upregulation of the vasoactive, vasodilatory peptides. And, and it combines that with valsartan. So by using the ARB, you'll block the vasoconstriction and decrease blood pressure, sympathetic tone, hyperaldosterone's effects. It's antifibrotic, reduces hypertrophy. And by inhibiting the breakdown, the sacubitril inhibits the breakdown of ANP, bradykinin, etc., it causes vasodilatation and contributes to a reduction in blood pressure, sympathetic tone, aldosterone, fibrotic, and hypertrophy effects. In a head-to-head double-blind therapy as initial therapy in patients with heart failure with reduced EF, the utilization of LCZ696 BID compared to enalapril BID was associated with a 20% highly statistically significant benefit in the primary endpoint, which is a combination of cardiovascular death and heart failure hospitalization. It not only reduced heart failure hospitalization, but it also reduced cardiovascular death. And the question is, where will this drug end up in our armamentarium? So the 2013 guideline did not have any comment on this because it wasn't FDA approved at the time. And where it will fall and where we will use it and what its price will be, the manufacturer recently said, given BID, it'll be about $13 a day. That's $420 a month. That's $4 a month for enalapril. The NNT is robust, but where will we use it? And when will the insurance companies allow us to use it? Unresolved issues. Just know about the drug. Case 2, 75-year-old white woman here for follow-up, history of diabetes, hyperlipidemia, and hypertension, has mild shortness of breath when walking from the car to church. Recently gained 15 pounds over the past year. She was hospitalized due to poorly controlled hypertension and heart failure 8 months ago. No history of coronary disease. She has one pillow orthopnea and frequent ankle swelling. This woman has an EF of 70% with a normal LV. She has LVH and atrial enlargement. She's on Amlo 5, atenolol 50, atorvastatin 20, and aspirin 81. Blood pressure 135 over 80, pulse 68, weight 285. No JVD, lungs are clear, cardiac regular rate, abdomen soft, non-tender, extremities 2+ bilateral ankle edema. So this woman has dyspnea and edema. She's older. She has a recent hospitalization for uncontrolled hypertension and heart failure. And here, with an ejection fraction of 70%, you're going to consider heart failure with preserved EF and the need for cautious diuretic therapy with potassium supplementation. Because when we've done studies in these patients, compared to placebo, we couldn't show that an ACE was more beneficial, an ARB was more beneficial, and most recently, we looked at a mineralocorticoid receptor antagonist. And here in the bottom left, with an excellent ejection fraction, we're trying to antagonize the risk factors, like hypertension, that contribute to a patient's having preserved EF heart failure. Although we used to call this systolic and diastolic dysfunction, the clinical trials enrolled people by their EF. And so it's the EF that defines clinically what we should do. We're not really interested in a whiff of this or a whiff of that. We want to know what the EF is, to know what our evidence base is for improvement. Women are more likely to have diastolic heart failure as opposed to systolic heart failure that's more likely to occur in men. Women are less likely than men to have coronary disease. Coronary disease increases mortality risk 2.5 times in women and only 1.5 times in men. So let's talk about what happens in patients with heart failure with preserved EF. In blue are all of us. It's a Saturday night. We're going to have some brewskis. We're going to have a few potato chips, a little salt. We increase our volume, and then we have a sense that we have to go to the bathroom. We never develop symptoms. We diurese, we feel better. Our left ventricular end diastolic pressure is reduced. We never felt symptomatic. On the other hand, our patient, 40 years of hypertension, EF 70%, but she also is going to take in some beer, salt, and potato chips. And for the same amount of diastolic volume, she generates an inordinate left ventricular end diastolic pressure. She senses fullness in her chest, shortness of breath. She calls 911. She's in the ER. She doesn't yet have edema, but she's got congestion in her lungs. She gets a diuretic, feels much better, caused her own hospitalization, and she's actually sent home. Blood pressure was not controlled when she first went in, but then after diuresis, it was much more favorable. This is exactly what happens to these folks. What happens? Why do they decompensate? Because they take in excess salt. They develop new atrial fib. They started NSAIDs or rate-limiting CCBs. They have an inadequate diuretic treatment. They have worsening hypertension, new onset myocardial ischemia, all things we should think about. Their renal function has deteriorated, so we got a creatinine when they came in. They have iatrogenic volume overload, perhaps from a TZD, or something else that we added. Or they develop new onset anemia with a reduction in oxygen carrying capacity. A nice checklist, I think, for us to think about when we see this. On the far left is the patient we're talking about. Randomized clinical trials have not shown survival benefit with any particular drug in patients with HFpEF. We need to control the blood pressure. We need to control their diuresis and their volume excess. We need to reduce their edema and control their symptoms. Now, this is a most recent study which looked double-blindly at spironolactone versus placebo in patients on good background of therapy with either an ACE or an ARB, a beta blocker, diuretic therapy. And in this trial, you can see, called TopCat, in patients with heart failure and a preserved EF, treatment with spironolactone did not significantly reduce the incidence of the primary composite outcome of death from cardiovascular causes, aborted cardiac arrest, or hospitalization for the management of heart failure. That was the primary endpoint of the trial. Everyone was so excited about what a mineralocorticoid receptor antagonist like Spiro at $4 a month might have done. But here's another one that bites the dust. So in the guideline 2013 with HFpEF, we have class 1 recommendations to control blood pressure, class 1 recommendations to use diuretics for volume excess, and then we have 2A and 2B recommendations to look at coronary revasc when they have angina or demand ischemia, when they develop new onset atrial fibrillation, when use of beta-blocking agents, ACE inhibitors, and ARBs are being used for hypertension. But it's not a class 1 recommendation. And a class 2B for ARBs that might be considered to decrease hospitalizations in HFpEF. Symptoms, blood pressure, risk factor control, prevention. Okay, third case, last case. 66-year-old white male, history of CAD, status post-CABG. Has an ischemic cardiomyopathy, HFrEF. Has underlying severe COPD with frequent use of inhalers and comes to you following a recent hospitalization for decompensated heart failure. On metoprolol 12.5 a day, long-acting, aspirin 81, atorva 40, albuterol 2 puffs 4 times a day. Blood pressure, pulse 85, weight 235. On exam, no JVD. Lungs scattered wheezes, cardiac regular rate and rhythm, no murmurs or gallops, abdomen soft, non-tender, extremities, no edema. EKG, sinus rhythm with non-specific ST T-wave abnormality. The patient has a relatively high resting heart rate of 85 and severe COPD. The scattered wheezes are likely related to the COPD and may be exacerbated by the long-acting low-dose metoprolol. What is the treatment option for this patient who may be intolerant of further dose increases in the beta blocker and has a high resting heart rate? So I'm going to present another new agent like LCZ696. And I'm not sure this is really going to be used in the primary care arena, but I want you to know about it. It's called ivabradine or Cordero. It's an inhibitor just recently approved of the funny current of the sinus node pacemaker. It's called the funny channel blocker. It's indicated for patients with stable chronic systolic heart failure, a normal sinus rhythm, and a resting heart rate of at least 70 beats per minute. They are taking beta blockers at the highest dose they can tolerate, or they cannot tolerate a beta blocker. Ivabradine was studied in a European non-US study done in 2010 of 6,505 participants called the SHIFT trial. Ivabradine reduced the time to first occurrence of hospitalization for worsening heart failure compared to placebo. The most common side effects observed in the trial were bradycardia, hypertension, atrial fibrillation, and temporary vision disturbances. For the first 2 weeks to 2 months, they get a sensation of what's called phosgenes, P-H-O-S-G-E-N-E-S, the flashing of light that dissipates over time with continued drug utilization. It has only 2 doses. It's 5 BID, and if the heart rate's greater than 60 after 2 weeks, you up-titrate, like in the trial, to 7.5 BID. European worldwide study, not done in this country. Very unusual that the FDA approved a drug with no American participants in the study. Here's the mean age, 3/4 men, 2/3 ischemia, class 2, 3, 4 heart failure, half previous MI, a third diabetic, 2/3 hypertensive. The mean heart rate had to be at least 70 or greater than 70. The EF, reduced EF. There's the blood pressure. There's the GFR. The primary endpoint was significantly reduced, but there was no effect on cardiovascular death. The only effect was on heart failure hospitalization. And the FDA approved the drug. The mean ivabradine dose is between 5 and 7.5 twice a day. So this study showed heart failure with reduced EF and elevated heart rate is associated with poor outcomes. Ivabradine reduced primary endpoint by 18%, but the absolute risk reduction was 4.2% with an NNT of about 25. This beneficial effect was mainly driven by a favorable effect on hospitalization for heart failure, but no effect on cardiovascular death, and overall treatment with ivabradine was safe and well tolerated. It's an interesting FDA approval in no U.S. patients, but it's out there and it's available for us in our practice. So based on data from the SHIFT study, this patient should benefit from treatment with ivabradine. This drug was recently approved by the FDA. Since the patient was recently discharged following hospitalization for acute heart failure, it will be important to coordinate the care with his cardiologist in order to determine the optimum timing and dose of ivabradine, because his pulmonologist felt we shouldn't go up on his metoprolol dose, which would have been the most logical thing to do in this patient. So let me just summarize what we've said. In heart failure with reduced EF, we have tremendous evidence for outcome improvement. Traditionally, we start with an ACE or an ARB. Don't really know which is best, but certainly the ACE inhibitor stacks up extremely well in both prevention and treatment of heart failure. After that, we usually add a beta blocker, but we only like long-acting metoprolol and carvedilol given BID. Although bisoprolol is available, it's not FDA approved in this country, but it is evidence-based, and that's known as Zebeda. We use diuretics, but only for symptoms. We use diuretics in heart failure with preserved EF for symptoms. If they're uncontrolled or still having symptoms on an ACE or an ARB with a beta blocker, we're going to add spironolactone or eplerenone. If they're African American, we might then add instead isosorbide dinitrate hydralazine. If they're intolerant of a beta blocker with a heart rate of at least 70 or greater and have had hospitalization for heart failure, we might use ivabradine, but we might allow the cardiologist to consider that. And finally, the role of digoxin is still unclear. It prevents hospitalization, but has no effect on mortality in patients with heart failure and reduced EF, and we still don't use it in preserved EF. So that's pretty much what we wanted to cover. So let me go to the questions, and then we'll have a little time. How confident would you be in the evaluation and the management of patients with heart failure? Not at all to very confident. Please answer now. Okay. Ooh, wow. Oh, we feel better. Very nice. Which of the following may be the single most important modifiable risk factor in women for heart failure in the U.S.? High blood sugar, high blood cholesterol, high blood pressure, cigarette smoking. Please answer now. The most important modifiable risk factor to prevent heart failure. Oh, look at that. Awesome. Hypertension, beautiful, right in the handout. Okay. In clinical practice, patients with stage A or B heart failure have which of the following features? One or more modifiable risk factors, symptoms of heart failure, multiple hospitalizations for heart failure, or need ongoing care and follow-up by a cardiologist. Very nice. Yeah, these are our patients. They don't have symptoms yet, but they're seen by us because they have modifiable disease risk factors or disease states. In an African American female with heart failure with reduced EF who remains symptomatic, shortness of breath, poor exercise tolerance, on an ACE, beta blocker, and diuretic, which of the following is evidence-based? Valsartan addition, spironolactone addition, combination isosorbide hydralazine, or implantable cardiac defibrillator with cardiac resynchronization therapy, which I didn't talk about. Very nice. Excellent. Which of the following is the most appropriate in a 78-year-old female patient, long history of hypertension, on enalapril, presents with shortness of breath, 2+ bilateral lower extremity edema, well-controlled blood pressure, pulse 65, EF 60%? Very good. So, can't improve their longevity. This is HFpEF. and we want to just keep them symptom-free, improve quality of life, treat their risk factors, and furosemide would be the appropriate treatment. Which of the following statements best describes your approach to treating heart failure in all patients? You don't treat it. I did not treat heart failure, but as a result, I'm thinking of doing it. I do treat heart failure, and this course helped me change my approach, or I do treat heart failure, and this course convinced me that I do not need to change my approach. Well, how gratifying. Very nice. Okay, I think that's it.